The topic for today's lunch panel discussion is state-of-the-art wellness. So I'd like to welcome Dr. Andra Blomkalns. She is the chair of the Department of Emergency Medicine at Stanford and a medicine professor in emergency medicine at Stanford University School of Medicine. Jay Kaplan, medical director of care transformation for LCMC Health in New Orleans, clinical associate professor of medicine, section of emergency medicine at LSU Health Sciences Center. Bernard Chang, assistant professor of, there you are, assistant professor of medicine at Columbia University Medical College, Department of Emergency Medicine. And finally, Sorabh Khandelwal, the Samuel J. Keel III, MD, professor in emergency medicine residency, program director, The Ohio State University College of Medicine. Sorry, had to get that one in. So, thank you all for being here today. Dr. Chang, I'm going to start off with you. A few questions for you, and then we'll open it up to questions from the group. So with all the interest in burnout research, what types of research studies do you envision our specialty tackling? Observational, epidemiologic, intervention? In other words, what are the deliverables of a program of burnout research?
No, it's an excellent question. I think it's something that we all discussed in the small breakout group sessions earlier this morning. And the way I conceptualize burnout research for us is, if you make kind of an analogy to a lot of the work on acute coronary syndrome, or ACS, you started, if you look at most of the historical cardiology researchers, they really first spent the first few years and decades describing a problem, like the epidemiology, the prevalence, the incidence of ACS, what happens after you get a heart attack, et cetera. And I think from there, they then developed a program of identifying potential modifiable factors, things that are stationary, things that are trait, et cetera. And I believe that what we can do with our burnout approach is a similar kind of model, namely that we spent over the last 10 or 15 years talking about the epidemiology, the description of burnout, and kind of what is the state of the field today. And we've arrived at a few potential interventions. And I think that this dovetails into this idea of, if we can combine up these interventions, how do we do it? And who are the people that can help support us for this? Because I think that with a research program, you really want to find some way of support, not just within your department, but both within the medical center and even from a research standpoint, external funders or foundations or the NIH, et cetera. And I believe that with a program of research that kind of transitions from just epidemiology more to impact, more to describing the impact of burnout, as well as the identification of modifiable factors, that could serve as potential areas of focus and expertise for emergency providers.
With so many people and institutions interested in research in this area, how can we leverage and capture all this collective energy to maximize that impact without creating redundancies?
So I think that if you look at one of the great things about emergency physicians is that we really deal with a whole host of issues, and we can pivot from both trauma to minor care to renal problems to neurologic problems, et cetera. And I think that that same type of cognitive flexibility can apply to the burnout agenda for research. What I mean by that is we even from this room today, I think there are a group of individuals who are full-time research investigators, there are administrators, there are medical students, residents, people who have somewhat of an interest in burnout but have another primary interest somewhere else. All of us have some role to play with this. And the way I envision it is, if you look at some of our large research trial networks in emergency medicine, such as the Siren Network or the Aurora trial going on, you see a core group of some institutions and some lead investigators who are really 100% dedicated into the research questions of the scientific questions, so with burnout. Complementing that, and equally as important, but playing a very different role, are some of the administrators who kind of help support the defining the outcomes, because oftentimes what researchers we sometimes miss is that while we might be focused on a specific question, we may miss out on the practical outcomes. I've experienced this myself when I submit grants, that I might think it's a cool idea, and I'll get feedback that, you know what, the outcome is not particularly highlighted by, say, the NIH or whatever funder that is. And I think having other invested individuals who have that wisdom and have that expertise, both from administration, from other leadership, from clinical faculty, that teamwork structure works well. And then lastly, I think that given that we are a diverse group of individuals spread out across the country, emergency medicine, as we saw earlier this morning, has among the highest rates of burnout among our profession of medicine. And we, I believe, can take the lead as the acute care providers in leading that charge for burnout, not just within our specialty, but within our field. And I think that leveraging that interinstitutional interest and that common desire to improve that can really be leveraged with networks such as this.
Okay, very good. Thank you. Thank you very much. Dr. Khandelwal, I'm going to move to you now. You've done some unique things with the wellness program at your institution. Can you explain a little bit?
Yes. Well, let me just start off, just to take a couple of minutes to kind of give you a little bit of a background. Well, I think we're all in the room especially realize why we're doing all this, right? I mean, I think there's a growing body of research showing the high burnout rates in emergency medicine, and not only emergency medicine, but the house of medicine in general. And then you look at sort of the disproportionate amounts of suicide that happen in our field. And I think we all know that. For me, it was a personal event that led to a significant crisis in my life a few years ago, and that led to a transformation in me. And it made me realize that our job to our residents is not just to decrease burnout in emergency medicine, but to help them live through life. You know, and it was a major event that I realized burnout is a big deal, but burnout in residency is maybe not the focus. It should be sort of developing life skills, because when the train hits, and it will hit most people, you have to be ready for that. And I don't think we train our residents to kind of get that done. So what we did in our program is that we developed a pretty comprehensive wellness program, not just focused on burnout, but about, again, life skills in terms of happiness, flourishing, whatever you want to call it. It's silly to sort of maybe pick out the details of what the right term is, but the right term is whatever it takes our residents to thrive in life, not just survive. At about the same time, we were lucky enough to get a $1 million endowment from a faculty member focused on resident well-being. The department matched it by another $1 million, so we had a $2 million endowment that was strictly geared towards resident well-being. And you would think that with $2 million, that would be a pretty easy thing to spend. And so we really thought a lot about how to sort of spend that money and to create a program that makes sense. We did a lot of research on happiness, flourishing, well-being, resilience, you name it. And realize there is an entire science out there on happiness. I mean, this isn't sort of voodoo. You can sort of get a degree now in positive psychology. Martin Seligman from UPenn. You can get a master's degree in positive psychology. There are things out there that clearly help people become happy. And so we sort of focused on that versus sort of focusing on specifically burnout. We asked our residents what we should do as a program, and interestingly, what they told us is they wanted more free time, but in a residency, that's just really difficult to accomplish. Some residents even said, well, why can't you just take the money from the endowment and split it up and kind of hand it out to all our residents, and maybe that would help. I took that into consideration for a couple of minutes, and we ended that. Some residents said, well, can you use the money to buy alcohol? And we realized that from a resident perspective, they were really focused on sort of the momentary benefit of what well-being, resilience, wellness was, and they weren't really understanding the big picture of how are they going to sort of survive life. So we realized a few things after doing this, right? There is a skill set to happiness, and we don't think that most people know that skill set exists, and we learned that from our faculty members and our residents, and just in general, our House of Medicine in general at Ohio State. Most residents felt that they had the resilience. You know, they felt that they made it through medical school, they made it through residency, they have resilience. Medical school and residency isn't the train. And if residents feel like that's the train, they're setting themselves up for awakening a few years down the road. You know, burnout happens well after residency too. It's not simply you get through residency and then you have this light at the end of the tunnel and you're going to be fine. I mean, burnout's a huge issue after you graduate as well. And we also realized too that happiness was individualized. You can't make everybody happy doing one thing. And as we talked to all the residents, we realized that everybody had their own little unique perspective as to what we needed to do as a program to make them happy. You can give them the world, and then all of a sudden they wanted coffee for breakfast, right? It was kind of crazy to a point. So what we did, we used the National Wellness Institute's 6 dimensions of wellness, and those are the emotional, spiritual, intellectual, social, physical, and occupational spokes or dimensions. And then we took sort of what the literature tells us are the true skills of happiness, right? The things like being present in the moment and altruism and thinking with abundance and meaning and purpose and cherishing relationships. There's a lot of science behind how those things individually help with happiness. Even things like forgiveness. Like we don't teach our residents how to forgive. We don't teach people how to forgive. And we realized that we set an entire program on those dimensions. So we sort of combined those skills of happiness into this 6-dimensional model. And we sort of offered our residents a chance to sort of learn the skills within that sort of framework, to give them sort of a blueprint on how to move forward, not only in residency and in life. So some of the examples that we sort of added to our program. So for instance, on the emotional sort of dimension, we really offered them books on self-improvement and things that would sort of help them move forward. Again, not just in residency, but in life. We offered a really easy access to counseling and psychiatry for the ones who needed it or who wanted it. We offered services on meditation for residents who wanted to kind of engage in that. And we tried to sell all this to them. We tried to really sell it and say there's a lot of science behind meditation. So when residents say this is kind of voodoo, we point them towards Daniel Goleman's book, on altered traits and why meditation makes a big difference on happiness. I think when you point people towards the science, it makes a big difference versus residents sort of saying there's this sort of voodoo out there and happiness is sort of not a skill. It's sort of you either have it or you don't. Occupational wellness. We started a Save of the Month. We really started to highlight, as some of you have mentioned before, highlight the good things in our program, the good things that the residents do, not just the M&Ms and all this other stuff. But we really try to tell them that what they do matters in their job. And sometimes, it's interesting, you think that as physicians we know what we do matters, but that's not always the case. I think they get lost in the administrative end of residency, they get lost in life, and so we've really tried to push that sort of meaning to them and tell them that you're a physician for a reason. And we're doing and will do some novel things, bringing in patient panels, who will let them know how meaningful their experiences were in the emergency department, and again, what residents and what attendings do sort of matter. Physical dimension, we've added something small like a community agriculture program, and interestingly, that's worked tremendously well. The residents love sort of getting fresh fruits and vegetables, and I know a lot of programs kind of do this, but boy, for a small thing, it really works. We've added things like the OSU Babysitters Club, where their faculty will actually babysit residents' kids so they can actually go out on a date. And you would think that the residents would have money to spend $40 to hire a babysitter, but when they break down the expenses that they have over the course of the year, there's not a lot of discretionary income. And I had my eyes open when a resident gave me a spreadsheet of everything they spent during the month and what they earned. And I realized, boy, a date night is difficult. So that's been a huge plus for something that we've done. That's something trivial that every program can develop, and it really has kind of gone a long way. As far as a social sort of setting, we've obviously developed retreats, and many of you have done that as well, class outings, faculty dinners, program director lunches. We've developed a family concept that's worked fairly well, so the residents are broken up into families. And we've kind of housed all this within this concept of a competitive spirit. So the endowment has allowed us to sort of offer rewards for participation, rewards for families that have done some remarkable things. So the residents do compete against each other individually and as families, and it's not trivial money. At the end of the year, for instance, a family who does the most in terms of these exercises on their way to becoming a happier person, each person gets about $250, $300, and for a resident, that's a lot of money. I mean, for some of us in the room, maybe $300 is a dinner, but for them, it's quite a bit. And one of the things that we've really developed too that's gone over well is a professional development fund. So with the endowment, we've created a fund that allows residents to actually ask for money that they can use for their professional and personal development. And residents can use that money for global health experiences. They can use that money for specific courses they want to attend. And it doesn't have to be all medicine related. It has to be something that they are passionate about. And we feel that if we can fund and fuel that passion, then maybe they can sort of take everything else into consideration as well. So anyways.
Very good. So I have a two-part follow-up for that. What was the impetus for the genesis of this endowment, this generous funder who came through with this? And did it buy happiness?
Yeah, it's a great question. Can money buy happiness? You know, we know that for a typical person, it takes about, I don't know, $60,000, $70,000, $80,000 before you stop being happy with money. I don't know what that is in a resident's perspective. Maybe for residents a lot less. But it doesn't buy happiness. But what it did allow us to do for a pretty small investment, right? It's I think the endowment gives us about $80,000 a year to kind of spend. It gives the residents a chance to experience things they normally wouldn't experience because they don't have the financial resources to do so. So, for instance, going on a global health sort of experience, you know, paying $3,000 to $4,000 out of pocket is almost impossible for them to do. But applying for a grant allows them to kind of do that, and it takes that off their plate. And the impetus for the endowment really was the faculty member was being pushed to different directions, you know, a chairs fund, research, et cetera. And I just had a heart-to-heart discussion with him about, you know, what's his legacy here going to be when he leaves, and I think we both mutually agreed that his legacy would be sort of the wellness of our program.
Wonderful. That's terrific. And any changes in the works based on what you've learned so far?
Just a few changes. I think it's going well so far. I think what we're trying to do, does anybody own a Peloton bike? A few. So you guys are involved in the Peloton culture, the cult that is Peloton. So Peloton is a company, a private company that probably will go public in the next couple of years that's really built its entire sort of model based on community. So what we are going to do going forward is really looking at the lessons that Peloton has taught us as a business model to really push wellness and well-being. Specifically, we were trying to do all things for all people and offering residents a chance to do everything, so we're going to tailor that down a little bit and really allow the residents to participate in things that we know can prove or can increase happiness, like exercise and meditation. So we're going to trim down the offerings that we have so it gives our residents a chance to experience the whole list of things over 3 years. And we're hoping that maybe they'll think it's sort of voodoo, but when the train hits, they'll have the experience to go back to that and say, that's in my toolkit, I can kind of use that. That's probably the biggest change we're going to make, and I think part of it is role modeling too. We've recognized that it's hard to be well in a program when the faculty aren't well. And role modeling is really important. So the one thing we haven't done as a program is really focused on that aspect. So I think we're going to try to hit that hard this year in terms of having our faculty realize the importance of what they say and what they do, and that it matters to the residents and how the residents view what emergency medicine is going to be like.
Very good. Thank you very much for sharing. Okay, Dr. Blomkalns. I've seen a lot about the wellness initiatives at Stanford in the media. And I'm curious how having such a prominent wellness presence has affected the experience at Stanford. You guys have the Employee Bewell Program, a Chief Wellness Officer, an EM Wellness Fellowship, and a Well MD and PhD initiative. So how has all of that come together to affect the experience there at Stanford?
So I've been at Stanford now for 7.5 months, and I remember being particularly struck by all the media and emails and stuff I started getting in my onboarding experience about the well stuff. And I say the well stuff because I'd get the Be Well and the Well MD, and then something about the Wellness Council, and then something about the Well-Being Committee, which, by the way, has nothing to do with wellness. It's actually for people who really aren't well and need help. So it stressed me out, right? And that's not exactly the cheap. So we are very lucky and blessed at Stanford to have a significant amount of resources for these different programs. So one of those is the Bewell program, and that's not simply for faculty only or residents only. It's actually for everyone, including staff and otherwise, and that's a variety of things like fitness club memberships, and they have different events, and that what Sorabh was talking about in terms of sense of community, and these things that you can get are berries, and I'm still not sure what are berries and what are other fruit. And but it's a total community. So what that does is it sets up the entire Stanford community as paying attention to wellness. And then we have Tate Shanafelt, who I know much of his research was presented this morning as the Chief Wellness Officer, and he is legitimately part of the C-suite. In higher meetings or the Council of Clinical Chairs, he provides input, and what he says matters, and he helps drive initiatives at Stanford, and that's pretty amazing. And he's a wonderful advocate for wellness, but he has really made it a professional activity that I don't think necessarily existed before. There are programs like the Well MD, and then to highlight that things might be slightly different perhaps in academia, the PhDs got upset and said we need wellness too. And so when you're looking at an entire academic community, which includes faculty, that can include faculty of different flavors and not simply the medical specialties, as well as the residents and the grad students and those sorts of things. There's also a well-being council, of which Corey Poffenberger, sitting right over there, is our department's esteemed member, and they're working on individualized projects with individual departments and addressing those on a long-term basis. So those are Stanford's initiatives, and then in our own department, we recently started a wellness fellowship, which is very exciting. We'll have our first fellow. We have something called WISE credits, which sounds similar to what Dr. Khandelwal described in terms of its wellness in Stanford emergency medicine, and it's basically credits that you are given initially, but credits you can also get for doing different things, like covering a shift on short notice, or providing mentorship, or counseling a resident, or doing those things, and just on an honor system people submit that and they get these credits, which can then be used for everything from food to dry cleaning to massages to exercise classes and whatnot. Now that was made possible by a donation, and interestingly it wasn't an endowment, so we're not living off the interest. It's actually you have $1 million and you can spend that $1 million, and when it's gone, it's gone. And the donor specifically wanted it to be surrounded a lot around how to reclaim time, and then also nutrition, food. And so there is a nutritious elements brought down in all food groups to a special resident wellness refrigerator and also in the nurses' lounge. So we have a lot of different initiatives. How has it affected the experience? I think the most beneficial thing is being part of a community that talks about wellness and that sees things about wellness all the time. So it transcends from something that might be voodoo or kind of hokey or touchy-feely or something to something that's part of the culture of the institution. And that is a huge difference. And I think that's the major benefit of all those things, whether people take advantage of them or not.
So what do you think are the main challenges for wellness and emergency medicine at Stanford or otherwise?
Sure. I think about this a lot. I think about this oftentimes late in the night and super early in the morning. I think we have to quantify pieces of wellness. And I've thought about it. I feel like wellness and burnout, they're lifelong problems. I remember being burned out in junior high significantly, and I just think that we can't think of it just as a resident thing, and once I graduate from residency I'll be better, or a attending thing or otherwise, that most people have some component of this issue, and to recognize it's a lifelong problem. Two, I think that we in emergency medicine are at the top of these lists for suicide and burnout for a reason, because our environment is very challenging, very fast-paced, lots of good news, lots of bad news, loss of control, and that wellness is too big. We need to define our niche. We need to define whether or not we're attacking wellness from an academic standpoint, a clinical standpoint, the life standpoint, the spiritual standpoint, and focus, because until we quantify what these pieces are and how to make it better, it's really hard to attract the attention of scientific literature and the public at whole. I think that specifically for emergency medicine, I have a theory, and I'd like to test it sometime with those of you who are interested, is that we're great recruiters, right, for residents, right? We can tell them all the exciting things, and you get to do all these things and all these procedures, and you have shift work, and you can go home, and your life will be happy, and it's exciting and gratifying, and all those things. I'm not sure we have given emergency medicine a fair chance by giving people a balanced assessment of what emergency medicine is. There's a reason why neurosurgeons and CT surgeons aren't at the top of the list, because they know what they were getting into. So I feel like we owe our trainees and our clinicians of the future an honest assessment up front before they choose the specialty. It's a wonderful specialty, an absolutely wonderful specialty, but people need to go in with their eyes wide open.
Well, you mentioned coming at wellness from many different fronts, and this group in particular is looking at the science of wellness. What is Stanford doing in that area?
Well, I think much of Tate Shanafeld's research was actually presented in this regard earlier. I think we're transcending from basically defining wellness from surveys and considerations of these different domains to linking it up to patient outcomes and errors in medicine. That is, I think, both a nice way to look at it and quantifiable, but it also attracts the attention of the lay public, lay press, and potential funding agencies. So I think it's moving towards the softer side of the research where very much it just needed to be identified. We need to describe what we're talking about to things that can actually be measured that people will listen to and that patients will listen to.
Very good, thank you. Dr. Kaplan, you're on deck.
Yep.
So Dr. Kaplan is a member of the National Academy of Medicine Action Collaborative on Clinician Wellbeing and Resilience, right? And in that group and here today, there's been a lot of talk about physician wellness and the institution, and can those two coexist? So in this, I'd like to know if you view the physician as a patient, can the physician and, can the institution and physician wellness coexist?
So let me define, view the physician as a patient,
Okay.
which means can the institution serve the physician in the same way or in a similar way to serving our patients. And many years ago, 1995, if not before, I got challenged by my CEO to create great patient satisfaction in the emergency department. And one of the things that I realized right up front was that unhappy doctors and nurses don't make for happy patients. And so it became clear to me that in the emergency department, simultaneously, we had to focus on creating a great place for people to work at the same time that we focused on creating a great place for patients to come for care. Now, that's difficult because most of us are trained as craftsmen or craftswomen, and our craft is to take care of the individual patient. We're not taught to step back from doing it, and ask ourselves, could we do it better, and how do I get everybody on board with doing it better, and for physicians in particular, how can I be a team player? Because if you ask a group of nurses, maybe I should ask the nurses in the room, you know, what do doctors think the ideal size of a team is? They'll usually say one, right? How many doctors does it take to screw in a light bulb? There are two answers. One is none. Doctors don't screw in light bulbs, they'll tell us to. And the other is only one. They'll hold the light bulb and expect the room to revolve around them. And while I think that's less true of us in emergency medicine, I just had my last clinical shift last Friday. I had the experience of having a number of residents, physicians who felt like the world revolved around them. So I think we still have to deal with that. Now, institutions usually measure the physician experience. We don't call it physician satisfaction anymore, just like we don't call it patient satisfaction. They usually measure the physician experience once a year, if they even measure it once a year. Sometimes it's once every 2 years, and they do that on the basis of an engagement survey. And that engagement survey can be done by Gallup or NRC Picker or any of the Prescani, any of the companies. And what they look at, two factors there. They look at the percentage of what's called top box, which is the 9s or the 10s out of a 0 to 10, or the definitely yes, the top box, top answer. They look at the percentage of those, and they want to see those increase. And they also look at the response rate. of physicians, and they feel like the more responses I get, the more engaged physicians are. That's a measure of engagement. And I think organizations are coming to recognize, some organizations are coming to recognize, that you have to do it more than once a year. And in fact, it has to be done on an ongoing basis, and that's what some of these programs are about. I think, I often say about patients, people don't know how much you care, and people don't care how much you know until they know how much you care, and I think the same is true of the medical staff. And so I think organizations have to prove to the medical staff that they care about them. And what does that mean? That means they have to ensure that what doctors get what they want, which is care quality for our patients, appreciation for what we do, responsiveness to our issues, and efficiency of our practice. And so I think that there are things that organizations have to do. Now, the real question is, how do you get them to do them? Because I wrote a question when Andra was talking, and first off, I'm humbled by the bright lights here in this room. It's really extraordinary. I wish I had known what you folks know right now when I was your age. But I think that that in general practice right now, I was going to say, I wrote a question, what if you weren't well endowed? And I thought, well, maybe that's not quite the right question to ask, but I figured a little bit of humor kind of might be helpful here, because Stanford has a lot of money to spend, and Ohio State has a lot of money to spend, and my organization doesn't. In fact, at our last senior leader meeting, the CEO said, good news is that our margin is we're 9%. The problem is our expenses are up 8%. Okay, so we have to do something about expenses. So the question is, how do you get organizations to commit to expense? And the answer is, you have to prove, one of my favorite terms these days is ROI, return on investment. And we have to do research, not just the what-ifs. I think we have to do research to prove that clinician well-being leads to improved outcomes and leads to less turnover. And you lose one doctor, Stanford quoted, one of the folks from Stanford quoted $500,000 to $1 million to replace a physician at Stanford. And for a nurse, it's $80,000 for an emergency department nurse. You lose 10 nurses in a year, that's $1 million. We have to make that ROI clear. The one thing that in the emergency department that really affects, if I'm going to be emergency medicine specific, it's boarding. Boarding is, you want to frustrate emergency physicians and burn out emergency physicians and residents. You want to have high turnover for nursing staff, have high boarding. And so one of the things that we've done, we have Epic now, all of our sites have Epic. One of the things that I get twice a day at 6 a.m. and 6 p.m. is I get a boarding report of all the patients in my 5 emergency departments who have orders written but are still resident in the emergency department. And I collect that data, and on Monday morning, the C-suite of each one of our hospitals, as well as the ED medical director and nursing director, get a list of what their boarding has looked like over the past week and how it compares to the previous week. And we are now having conversations about the data warehouse that we need in order to drive hospital throughput so that we can decrease ED boarding. If we could decrease ED boarding, I could save our organization millions from turnover and from walkouts and those kinds of issues.
Well, one significant thing from the discussion so far would you recommend that our guests here take back to their institutions that they can use to institute physician wellness?
In the emergency department, my dad, may his soul rest in peace, said, keep it simple, stupid. And one of the best ideas that I've heard here, and the simplest that would be very easy for us to implement, is the monthly Great Case Conference. A monthly conference that would highlight a case where everything went well, and what did we learn from everything going well, and then how can we repeat that rather than how can we prevent what didn't go well.
Well, that's right in line with your strategy for affirmative instruction, informative interviews. So
Appreciative inquiry, and we'll talk about that a little bit in our...
very good.
in our
I'm going to open it up now to
subcommittee.
our audience to see if anyone has any questions for our panelists.
So I'm curious about boarding because that's a huge issue at our institution. And we are kind of stuck in a situation where we accept outside transfers before we admit patients to the emergency or from the emergency department. How would you potentially change that? And how do you decrease boarding overall?
Probably some folks here can also answer that. I'll take the first pass on that. So the first pass on that is that you have to have data. And in the emergency department, we have our throughput dashboard. If you ask your inpatient colleagues, do they have a throughput dashboard? And by that I mean percentage of patients with discharge orders entered by 11 a.m., discharge order entered to patient departure to room clean to next patient in bed. That's the data that you need, and then you need to tie that data again to return on investment. My CEO for our system said to me, this is now about 3 months ago, 2.5 months ago, said to me they got the market share report and emergency department volume was down at one of our large hospitals on the West Bank. And he said, why is that the case? So I had the data. So I said, well, the reason is because we were boarding, it's a 27-bed emergency department, because we were averaging boarding 15 patients a day. And they actually do go on divert because they're not a trauma center. They were on divert 78% of the time in January and 54% of the time in February. You want to know where our market share went? I often say, diversion is a direct cash infusion into the financial veins of your closest competitor. So that got him very interested in this, which then led to my being able to get the report that I needed. And now we're talking with a former colleague of mine in New Jersey who has a data warehouse who can take all sorts of data and give us the information that we need. So I'm hopeful that that will happen. It has to do with hospital throughput. And there will be something coming out from the American Hospital Association. We did a co-conference with them last July. There'll be some articles coming out from the AHA, 4 proven strategies to decrease boarding. And they include early discharge, weekend discharges, having a 7-day-a-week hospital. You have to determine why aren't people being discharged on the weekend and what do you have to do to make that happen. Smoothing of the elective OR schedule and the full capacity protocol.
Yes. So I think a lot of us have mentioned research as being sort of an important next step, especially sort of moving away from surveys and more towards patient outcomes. I'm kind of curious, because burnout, as far as I know, doesn't have a natural home in terms of funding agencies, and to do large-scale patient outcome studies takes money and effort and time. Do you guys have insight as to how that is possible, or are there things developing in the pipeline for people who want to do that kind of work?
So just as a quick rehash in case other people in here, what are the possible ways of getting the support for carrying out research programs like this outside of just the department or your local institution? So at least speaking to my own personal experiences with doing some burnout research, surprisingly, my burnout research is funded by the National Heart, Lung, Blood Institute. And the way we kind of structured it was our main focus was really looking at clinician wellness and clinician burnout. But we realized that if we frame the outcomes just by that, it would be very difficult to sell that to specific types of funding agencies. And we've come to realize, just in this discussion this morning with our colleagues here, that burnout potentially impacts all players within the healthcare system. So what we've done is that we found that oftentimes when you're defining your study question for burnout, you think of it in the framework of, okay, there are funding agencies such as the NIH or AHRQ or private foundations, and you think about what are their mission statements, and you kind of access that's very accessible looking on the website or talking with the funding officers, and you think about, well, I have my main goal. So my main goal is looking at, so the study we're looking at is a longitudinal study, like a TIMI study. So you follow like cardiac survivors and seeing their disease processes, but a TIMI study for clinicians. So what we're doing is we're longitudinally following nurses and physicians over years and looking at the development of not just burnout, but also cardiovascular outcomes, health outcomes, and their own like health utilization compared to a cohort of individuals who didn't go into medicine. And we're kind of also modeling how does the impact of ED crowding and hallway care, how does that impact the provider burnout, as well as how does that impact patient care outcomes. So we also, just one of the nice things with collecting big data is you can look at how does that touch on patient medication administered or medication errors. And so I think that if you can frame your burnout or wellness question in a larger context of how it touches the healthcare complex, for lack of a better word, you'll find that there's actually a lot of different sources for this. And then lastly, I think this is just what the main hope from this consensus conference too, is that we realize we really are a community of like-minded clinicians who really want to advocate for our fellow providers. And so this network is here, so we all have our contact information too, and it's one of those things that I know it's I myself get very confused about this too, finding where, quote, the money is for research. And I'm always happy, either myself or I'm sure other colleagues here, to either bounce off ideas or introduce someone to another individual, because this is what really this kind of consensus building is about.
Just wanted to add a couple things to that question. One, I think yes, wellness doesn't have a defined society or organ system where you can get funding, but that also presents a really significant opportunity. It's just a matter of framing the question in a way that different funding organizations can understand. And I think it's more of an opportunity than actually a hindrance. And to get back to the patient boarding, Jay was talking about data. Data does work. In our system, we have data that when we're boarding and also not accepting transfers that goes out every morning from the CMO that says this is our percentage of discharges at this point, basically get it done. And there is a spike over the next hour or so of discharges that happen. Now, why people are reading their email and not actually discharging people is a whole other question. And we also do inpatient hallway beds. And that is, I was really surprised to see that. So there are certain thresholds once patients can go up into hallway beds, and that does help, and does help our boarding significantly.
I'll just add one thing if I can as well. The EMF, the Emergency Medicine Foundation, a number of years ago decided that they would put a significant amount of resources towards health policy issues. And this clearly is a health policy issue for us. So I would say that. The other thing is just to alert everyone, the National Academy of Medicine Action Collaborative has a consensus committee now that's looking at research and looking at solutions. We'll come forward with a paper that we think will be similar to the landmark 1999 paper, To Err is Human, that really profoundly affected the landscape in terms of patient safety. We hope that it will profoundly affect the landscape in terms of clinician well-being, and we think the title of that potentially might be To Care is Human. So I'm hopeful that once that paper comes out, that consensus comes out, that will stimulate many more resources to be available.
My husband is actually a researcher and has his PhD, and reminds me frequently that as a MD, we don't have that background in terms of research, and we're trying to do research or create these research questions and develop research projects. What can we do as MDs? Who can we reach out to and who has this knowledge and pull those people in to collaborate in order to get a better design and better research question?
I think you can try to structure it perhaps in two general pathways. I think there's what I call like the pathway one, where we do see a lot of MDs, emergency physicians, taking the investment to do a research fellowship or kind of go back and do a master's in clinical care outcomes, or even some individuals going to do a PhD. that's one way to kind of get that methodological background and experience in study design and statistical analysis, et cetera. The way I see it, I mean, like, so I have my PhD in neuropsychology, and I got my PhD prior to going to medical school, so I've always had a little bit more of kind of like this PhD mindset in terms of addressing study questions, but I've come to realize that it's a tremendous strength as an MD with the questions that you can think of from a research standpoint. And I think you should never undersell yourself from that, especially as an emergency physician. You get the ground as you're both the infantry and the general at the same point, that you are on the ground seeing kind of what are the biggest factors that are real world externally valid. And also you have the ability, the impact to quarterback a lot of these changes. So I think the one path is taking that, what I call formal educational pathway. The second pathway also is, remember, as researchers, there are different flavors of research insofar as you can definitely serve as a strong advocate, a co-investigator, administrator, leader, with partnering with other experimental scientists who can kind of have their domain of expertise with, say, doing the power analysis, while your domain of expertise is really kind of constructing the critical question. And I think that the team science approach to this, Jenny, allows, I think, all of us in this room, no matter what your research background, to make a significant contribution.
All right, we have time for just one more question, but before that, I want to make a couple of announcements. If you did not sign up for an afternoon session, you can do so at this front round table, so please do that. If you didn't get lunch, they brought in some extra sandwiches, so please have a sandwich. And after this last question and answer, we're going to take a quick break and ask everybody to be back here at 12:45, and we'll talk about our afternoon sessions. Last question.
So there's a book that is by some authors, Barrett and Spielman, and it's called The Patient Comes Second. I don't know if you've ever read that, but I think that that's the key to us being well. I think we have to get back to basics. This physician touched on she can't get to the bathroom, have some food and water. I'll work like a dog, but I need to be able to go to the bathroom. I need to have some food in my stomach, and I need to be hydrated. And I think that that is across the board the problem for all of us. And so what I'd like to think about and bring into this is, how do we look out for each other and get back to the basics and talk about humanness, being able to go, doc, you're not looking so good. That was a rough thing we just went through. You need a hug? I mean, that sounds kind of stupid, but that's who I am. And I do that with my fellow nurses, and we'll break each other. I'll be like, you know what, I got to get out of here. Good, great, I'll cover your patients. And I would hope that physicians could do that more. And so I guess my question is anybody out there actually doing that, not just physician to physician, but bringing in your whole team, your respiratory therapist, your techs, your whoever? Are you really saying, hey, I'll do this for you so you can get out for a few? When's the last time you ate? Is anybody looking at that and doing it well?
I'll just say we've done a couple of things at my institution, one of which is the nurses typically have a morning huddle, nurses and respiratory therapists, other folks. We have a morning huddle. It's at 7 a.m. and then at 7 p.m. And the attending physician from our pod 3, which is our non-resident pod, does a medical minute every morning at 7 a.m. and then at 7 p.m. Of a 1 to 2 minute discourse, educational thing on talking with the nurses about something of interest to them, or an interesting case, or that kind of thing. I find that nurses really appreciate that education, and it creates more of a bond. The other thing is that in academic centers, I think faculty often pay more attention to teaching the residents than they do to communicating with the nurses. And in this day of the electronic health record, we have to make a real attempt. So one of the practices that we've started, besides bedside change or shift, one of the practices that we've started is that after the physician's round, if the nurses are not available to round with us, the resident running the unit or the attending will walk up to the nurse and say, is there anything you need from me? And that simple question, and we also kind of promote board rounds, not just the residents coming to me, but rather having the residents go to the nurses covering their 4 patients and say, can I run the board with you? Is there anything that you need from me? It can be really helpful, and the nurses very much appreciate that. The other thing I think that we don't do enough of, if your emergency department does not have a recognition and reward, a departmental specific recognition and reward program, you need one. And they are very simple, and they cost next to nothing, okay? And they can be profoundly effective in terms of focusing on all the great work that people are doing.
I just wanted to comment on the book, The Patient Comes Second. There's a really important guy who just died. He is the head of Southwest Airlines. And a lot of the information that we're getting today, a lot of the practices can be seen in non-medical organizations. They're actually doing a better job than we are. But with Southwest Airlines, Herb Kelleher thought that LUV, love, was most important. And so what he told all his employees at the inception of making the airline was that the staff comes first. It's not the customer that comes first, it's the staff that comes first. So what they did is their staff was so empowered and felt so cared for that they made lots and lots of happy customers. So maybe the patient comes first, maybe the patient should come 1.5. Maybe we need to share that spot with them. But that was just a thought that came up when you mentioned the book.
Also, if you haven't read Tom Peters' recent book, The Excellence Dividend, where he says the hard stuff, that is graphs, action plans, etc., that's actually the soft stuff, and the soft stuff, which is about relationship and listening and extreme humanness, is actually the hard stuff and the most important stuff.
Well, thank you, everybody. Let's take a quick break. If you could be back here by 12:50, and then we'll talk about the afternoon sessions and then kick off those small work groups. 12:50.